Okay, so we are at 30. Want to thank everybody for hopping on tonight. I'm going to turn this over to you, Dr. Didek, and you're going to go through some great information about educational information on shoulder pain. While he's going through his slides, if you have any questions at all that you want to put into the Q&A chat box, you can do that that way. You can also raise your hand. All yours.
Give me 1 second. I'm just loading the screen. For some reason, my screen decided to get small. Now I can see it again. Hello, everyone. I'm Dr. Alexander Diddick. First, I'm a sports medicine physician, followed by an interventional pain physician with Healthy U Clinics. I did my initial background in family medicine and then did 2 fellowships afterwards. I kind of came on at Healthy U Clinics and been here for about 2 years now, kind of growing their kind of pain division. Wanted a wonderful opportunity to talk to you about peripheral nerve stimulation, and specifically, we're talking about for chronic shoulder pain, where we're targeting both the suprascapular nerve as well as the axillary nerve. I'm happy to answer any questions after this. Get a lot of good information kind of going forward. And ultimately, our goal is to give you the best information kind of possible moving forward, so you have a good understanding of what we're talking about when it comes to stimulation, what we're looking about, what the process is when it comes to something like a stimulator kind of trial, as well as looking at a permanent implant long term. Go ahead, you can advance the slide. So as we talk about our agenda, I mean, no mystery here. One of the main reasons why anyone's kind of watching this kind of webinar talking about is generally we have chronic pain. There's a bunch of different types of reasons why we develop pain. Chronic pain can be both something that is related to kind of structural kind of changes, which could be something like arthritis or rotator cuff injury, or it can be something that's kind of neuropathic or nerve related that also occurs kind of chronically over time. And sometimes it's a little bit of a chicken and an egg situation where there could be an initial injury that is something that is mechanical, like arthritis or rotator cuff injury, and then it progresses over time to something like a nerve injury. And we're going to talk about that kind of in the later slides, but I wanted to set that up here. Go ahead, next slide. Okay, so chronic pain. There's a bunch of different definitions with this. Some people will label it after 3 months. Some will say it's after kind of 6 months of duration. But the big takeaway with chronic pain is any pain that's outside of the normal healing process. So if I injured my shoulder and I had a rotator cuff strain and I expected this to get better over a couple months, and it wasn't getting better, and it's been 6 months now, and we've gone through conservative therapy, including things like physical therapy and medications, maybe injection care. Maybe at that point, someone's gotten an MRI on their shoulder, and that MRI on that shoulder says, hey, this rotator cuff looks healed, for example. At that point, this is outside of the normal time period of healing. And if it's not getting better at that point, the chance of it getting better on its own, unfortunately, decreases as more time goes on. So 6 months is one example, but if this has been going on for 2, 3 years, then it becomes even more and more of a chronic situation that may not be improving. Ultimately, when we're looking at these pains, we were mentioning kind of in the previous slide, you can be having something like more of a mechanical pain coming from bones, tendons, our muscles, all of these kind of are contributing factors. Also, if we're looking at something maybe coming from the nerve, right? There's some main nerves that we kind of talk about a lot of times when it comes to the shoulder. One of the main nerves kind of send signals from the area that they're innervating. So if it's the shoulder, the most common nerves that go to the shoulder are the suprascapular nerve, as well as the axillary nerve, are two of the main nerves that go to the shoulder. And those nerves sense pain. And pain that we're feeling in our shoulder, going from that suprascapular nerve or axillary nerve, travels up basically from the shoulder to our spinal cord and our neck and goes to our brain. And once it reaches our brain, we experience pain. And if that injury occurs anywhere along that kind of process, let's say that nerve could be pinched, let's say that nerve initially occurred from an injury that was related to something that's also mechanical. If you have someone who's got a car accident that has a shoulder injury, they may dislocate their shoulder. They may cause trauma to the shoulder. All of those things occur, but there may also be a nerve injury that can occur. So it can be both something that's mechanical as well as something that is neuropathic or nerve related. So it can be a combination of both of those things. Go ahead, you can do the next slide. So when we're treating chronic pain, again, part of the whole point of a webinar like this is kind of saying, what have we tried and where are we along the kind of treatment at this point? And so if something is acute, we can say, okay, let's rest this, let's put some ice on it and call me in the morning. But again, we're talking about chronic pain. And often when someone's got chronic pain, we've tried many conservative managements. And it's very common for me to see someone who's gone through physical therapy, they've gone through a home exercise program. They've allowed the natural healing process, which honestly is one of the most important parts of this. We've tried injection care. We've tried various kind of medications for better or worse that may or may not be helping very much. They may even already had surgery or may not be a surgical candidate as well. And so where we talk about neurostimulation kind of fits in both in cases that are largely non-surgical candidates, maybe someone who's not willing or wanting to go to surgery, or someone's already had surgery on their shoulder as well. And so we look at this as a modality that can be an excellent way of reducing pain by blocking the pain signal. Now, part of this still requires us to do a little bit of hunting where we're saying, where's the pain actually coming from? Is the pain coming from the shoulder? Is it coming from the neck? We tease these things out both through physical exam, imaging, injections, these kind of things. So for the purpose of this webinar, we're saying we're very confident in saying the shoulder pain is actually coming from the shoulder. Okay, next slide, please. So neurostimulation, kind of mentioning a little bit in the previous slide, just how the pain signal travels in our body. So if we have pain coming from our shoulder, and we'll use an example again of osteoarthritis, which is loss of joint space over time. Our shoulder is a ball and socket. If we're losing joint space over time, like the cartilage and the bones are getting closer together. But when that happens, it can cause inflammation, it can cause irritation, or just pain from a lot of pinching and irritation with movement. That pain signal is sent to the main kind of nerves in our shoulder, essentially. So it's going from the joint and it's being interpreted initially by that suprascapular nerve, a lot of times a few other nerves in our shoulder, including the axillary nerve, that is kind of the center point where it goes from the joint to those nerves and then travels from those nerves basically to the spinal cord, to the brain. When we are talking about neurostimulation, we're talking about often blocking that pain signal at various parts along that chain. Spinal cord stimulation is often blocking that process at the level of the spinal cord. If we're talking about peripheral nerve stimulation, we're blocking it at the point of the peripheral nerve. And in this case, we are talking about the suprascapular nerve and or the axillary nerves. Those nerves, if the signal is blocked where the pain generator is coming from, say the suprascapular nerve, is being blocked so that the signal from the arthritis in this example cannot be interpreted, pain is just diminished completely. So essentially, if we block the pain signal from reaching the brain, we cannot experience pain to the same degree. This can eliminate all pain or it can significantly reduce pain altogether. Let's go ahead, next slide. So peripheral nerve stimulation in terms of our body can be done at any nerve that is what's called a mononeuropathy or single nerve distribution that causes pain. Most commonly, this is seen in the shoulder. It also can be done in the foot and ankle. It can be done in the knee. It can be in the low back, or it can be sometimes I'll see people for the abdomen where they have pain for some nerves such as the ilioinguinal nerve, maybe something that occurred where there was a nerve injury or nerve damage after surgery. That can happen anytime someone breaks the skin. A nerve injury can occur. Anytime someone had trauma, anytime someone's had anything really happen in terms of manipulation of the tissue, a nerve injury can occur. There could be nerve entrapments that also occur as well. So when we're looking at peripheral nerve stimulation, there's multiple different areas of the body where this is a possibility of being able to block the signal. And specifically for peripheral nerve stimulation, we're targeting the individual nerve and comparing that to something like spinal cord stimulation, where you might be blocking a whole segment or a whole area that might be interpreting someone's pain, like their foot or their low back in general as well. Go ahead, next slide. So who is a good candidate for peripheral nerve stimulation? And again, going through what we've built up so far, these are candidates who've been having chronic pain for quite some time and have failed conservative care. We've done multiple previous treatments. In general, for someone for peripheral nerve stimulation, we're also doing something called a nerve block very often, where we're numbing the nerves, we're numbing the suprascapular nerve, we're numbing often the axillary nerve under either fluoroscopic or X-ray guidance or ultrasound guidance. We're seeing how much pain it takes away. This is not a requirement, but it's also a very good indication of someone who's an excellent candidate for peripheral nerve stimulation. Because if we're able to block the pain signal by numbing it, then we're pretty confident that being able to do a stimulator trial where we block that pain signal with an electric current can also be very helpful. There's multiple different patients who present as stimulator candidates for chronic shoulder pain. As I mentioned before, if someone's had really significant arthritis, maybe they're not a surgical candidate. Maybe they're either their health doesn't allow them to go through the process or the recovery. Maybe it's due to someone's age. It can also be related to, as I mentioned before, a nerve injury. Could be something that is someone who is a poor surgical candidate because the joint itself has deteriorated significantly or had severe osteoporosis or thinning of the bones that make it a poor candidate. Or it could be something like complex regional pain, which is a very significant pain disorder where the entire limb or the joint itself becomes disrupted due to an ongoing kind of amplification of pain. Pain disorders can be very complicated or can be very straightforward in terms of saying, hey, there's a tear in your rotator cuff, and that's what's been causing the pain all this time. Go ahead. Next slide. So why do a neurostimulator? So neurostimulation, to review, is something that we look to block the pain signal generally with an electrical kind of current. Basically, in terms of this wire that we end up kind of putting underneath the skin near someone's nerve and near that injury, and right next to where the nerve is being injured, and by doing so, we are able to often block or significantly reduce the pain signal. So think of it as a radio wave, kind of going through the atmosphere. That signal is being sent from your shoulder. It goes up to your spinal cord. It goes as interpreted to your brain. And essentially, if we can get to that signal before it reaches the brain, we don't experience pain to the same degree. It's very wonderful how we can do this. It is an interesting, long story that is outside the scope of this when we look at the original forms of stimulation with tonic stimulation to progressing into modalities that can significantly just block the pain signal or have an absence or pain or significant reduction of pain. Very traditionally, the way stimulation has been done is by giving someone more of a buzzing or tingling kind of feeling that's kind of going to the limb or the low back. We're able to disrupt the pain signal that way as well. A neurostimulator is something that is reversible. It is something that often we do a trial first. It's a requirement that we end up kind of doing in office where we place these leads or electrode underneath the skin near that nerve, and we tape it down for about a week and kind of have you do all your normal activities during that time period, and we see how much pain it takes away. So that process also has a trial period before we do a permanent implant. A permanent implant is, as it sounds, where those wires end up buried underneath the skin, where we have an external battery, which allows it to be charged kind of over time. We can do other things as well during this time period. So ideally, what we're trying to do is say, hey, if you're a good candidate for a neurostimulator, do we identify that candidate through something like a nerve block? Have they failed conservative management? And at which point are we going to move forward with something like a stimulator trial? And if someone has a successful trial, then we have a discussion about moving forward with an implant. The device itself and the settings of that can be controlled by the patient. This is what's one of the wonderful things about that, meaning it is in the patient's best interest to be able to program and work closely with the representative so that we have an understanding of saying, hey, this is a time period. This setting works better when I'm laying down. This setting works better when I'm up and moving around. And it allows you to have some flexibility to the device itself, that it's not a one size fits all in how the device is programmed. Go ahead, next slide. So the Nalu neurostimulator system, an image on the bottom of the right screen, the micro IPG, that is about the size of your thumbnail. that ends up going underneath someone's skin, that it actually is connected to the leads. The lead that ends up being buried underneath your skin is near the nerve that is causing the pain signal. Externally is the therapy disc, and the therapy disc is outside or laying on top of the micro IPG. However, the micro IPG, as we mentioned, is underneath the skin, while the therapy disc is on top of the skin. And while the controller obviously looks like a cell phone, because it basically is and can be controlled that way as well. And so to go through this process, if we look at the text on the right, the micro IPG is implanted and produces these kind of mild electrical impulses, as we said before. The size of it basically means it can kind of go anywhere. In terms of the shoulder specifically for the purpose of this webinar, it can be placed in a few different spots. The most common is kind of on the top of the shoulder. And then the therapy disc is kind of sitting on top of the shoulder. Ultimately, there's an adhesive that kind of keeps that therapy disc in place. Those thin wires that we discussed are called leads, and those are also buried underneath the skin. And that wearable therapy disc allows us to have control as long as we're using the remote control, which is done on a smartphone. Okay. So why are we choosing this? These are very tiny devices. Okay. And so I think this is wonderful. There's no implanted battery. The power supply is external, like we mentioned before. The actual need to replace a battery is eliminated because there is only an external battery. The kind of cool part about that is if we've got an external battery, that also allows us to update kind of programming kind of over time, because the battery that's external can constantly be updated kind of over time as well. This is a minimally invasive in terms of both the trial as well as the implant. It is a very small incision that we end up making to get the micro IPG underneath the skin, as well as those leads that get kind of driven towards the nerves. Ultimately, this therapy, if we're comparing it to something like spinal cord stimulation, on the right is generally the size of a battery for a spinal cord stimulator. That's often about the size of a Tic Tac box is the way to kind of describe it. And so for areas like the shoulder, for example, those batteries are a lot of times driven all the way down to the buttock area. So there's a wire kind of underneath. So it makes it very, very challenging, or they're kind of anterior or on in front of someone's chest. And so having an external battery and having that micro IPG really allows you to kind of place these in areas that otherwise would be very challenging otherwise. Go ahead, next slide. So what's the process? So when I have a candidate for someone interested in moving forward with peripheral nerve stimulation, we have them reach out to our representative. One thing that we kind of show them is what the external disc looks like. They can even kind of trial kind of what this kind of feels like to have this external disc underneath your shirt, kind of walking around doing our normal activities. Separate from that, we end up doing something like the trial, right? So this is a requirement where we bring you into the office. We do this generally under an X-ray camera. We kind of drive those leads right next to where the nerve is located. In this case, again, typically the suprascapular nerve and axillary nerve. Those leads are then basically either sutured or often taped with taped down for the course of the trial. Those stay there for about a week. And during that time period, the device has been programmed by you and your representative. And I want you to do most of the activities that cause you to have pain. Obviously, they're just kind of taped down or sutured down, so we can't go throwing a baseball that much at that point. But ultimately, if we're having trouble doing our normal household daily activities, sleeping, doing things, we want you to be able to do those activities because we want to see how much pain relief we get during the trial. At the conclusion of the trial, I have you come back in the office and I remove those leads, which is very simple. And then we see how we've done. And the majority of the cases are very successful. When we have a successful trial, now we are moving towards something like an implant. And an implant, as the second kind of part of this, ultimately is very similar to the trial in that we're trying to reproduce the exact outcome of the trial, but we're keeping it there permanently. And so instead of these leads or wires being external to the body, we make a small incision that helps those wires or leads be buried underneath the skin, as well as placing this micro IPG underneath the skin as well. Then we either place a few small sutures underneath the skin, and then kind of close the incision. As that kind of heals, it heals great, wonderful. Then we place the external disc onto that area. The device is activated. Go ahead, next slide. And then the whole point of this, the whole process of going through this in the beginning, is to be able to go back to activities that you want to do. We don't do this unless it's affecting someone's life significantly. We don't do this unless someone's gone through conservative management. And again, that conservative management may all the way extend to things like injection care or medications or physical therapy, as well as on the other end of the spectrum where someone's already gone through surgery and maybe they're having persistent pain at that point as well. And so what we want you to be able to do is get back to being you. We want you to be able to do the things you want to do. This is all about quality of life. It's all about function and all about using your shoulder as it's designed to. You want to be able to reach for things. You want to be able to lay on your shoulder. You want to be able to move without thinking about pain in your shoulder. That's the whole point of us doing something like peripheral nerve stimulation, both starting with the trial and then moving towards the permanent implant. Go ahead, next slide. Okay, that's a lot of talking for me. I know patients will have questions. They'll reach out. This webinar is being recorded as well, so they'll come back at me as well. Do we have any questions currently?
Yeah, so thank you for that. That was wonderful. I have a few questions for you.
Sure.
So my first question here is this covered by insurance?
This is typically covered by your insurance. The majority of Medicare has wonderful coverage. Many private insurers are covering this as well. I also see, depending on the etiology or the reason why we're moving forward with this stimulator, I also see coverage kind of all across the board for this from that standpoint as well. If I've seen someone who's had multiple surgeries in their shoulder, that often with persistent pain pattern afterwards, that often does meet a criteria for something like complex regional pain, which I kind of briefly mentioned, which is a little bit outside the scope of this. So even when it's not just kind of straight shoulder pain or maybe just kind of regional kind of pain that's causing this, but the shoulder. And so, oh, we lost the recording for a second there.
Yeah, I
Uh,
think that was the cloud we have to blame for that, but we're back.
okay. All right. I don't know if I'll re-answer this question, even if we
Okay.
cut out for a second. So during the trial, we're not going to be bathing and we're not going to be swimming. We're not going to be, we're not going to be taking a bath during that time because those wires are kind of external, mostly sponge baths for the 5 to 7 days. And yeah, if you're lucky, you can kind of put one foot in the shower, but I don't usually recommend it. In terms of the permanent implant, everything is underneath the skin. So if you want to go to the pool, you just remove the battery and you go swimming. Essentially, second you get out of the pool, you can dry off, and you can kind of put the battery kind of back on at that point. You can bathe, you can go in the bathtub. All of those things are definitely uh, typical, when someone has had a permanent implant.
Great. So just one more chance here. If you have any questions or concerns that you'd like addressed, you can put those in the Q&A box. And my last question that I have for you is, if I have a shoulder replacement, am I still a candidate for this therapy?
Yes, I think post-surgical is also one of the best candidates for this because if you're having persistent shoulder pain, knee pain, any kind of area that's kind of been surgically replaced, there's not really a reason for you to have persistent pain there other than the nerves being affected. The nerves, again, can be affected a few different ways, one being a nerve injury, but often that's not the real reason why. The reason why is nerves become sensitized. This is a whole kind of process of how pain works, which is if you've spent years with shoulder pain, even after we have corrected it surgically, we replaced the joint, for example, you can still have persistent pain because the nerves have been in this pain state for so long that they're just kind of activated permanently. And so using something like a stimulator and getting these leads to block that signal is probably the best modality by far to correct that kind of pain.
Great. That is all we have for questions. Any closing thoughts?
I think one of the things that I would take away from this is anyone with kind of chronic shoulder pain that's been persistent and really affecting their quality of life for quite some times owes themselves a trial. Because a trial really kind of dictates if we're going to do this thing permanently. And a trial isn't something we move forward lightly either. But essentially, we're talking about chronic pain. We're talking about chronic shoulder pain, often patients who have had surgery before and having persistent pain, or someone who's not a surgical candidate. And at which point you're saying, do I want to move something forward with something? This is something that's, underneath my skin. It's got to be a part of my body. And often that's a decision we make a lot easier if we know we've had significant pain relief after a trial. That's the whole purpose of having a trial, is so that you can make informed decisions about moving forward with an implant. And that's it.
Great. Well, thank you so much. I really appreciate your time, and thank you to everybody who hopped on. And this, as Dr. Didick mentioned, is recorded, and just give the office a call with any additional questions or thoughts.
Awesome. Thank you so much.
Thanks
Appreciate
so
you having
much.
it.
Have a
Take
great
care.
night.